Okay, now that we've established a rapport, and I'm gonna lose it, what are you doing with your babies? Oh my God. So you can see that she's adopted that posture where she's really, she's leaning heavily here. She's got a little shortened curve here. You can tell just by the way she's sitting that she's not trusting her hemiparetic side at all. So some of the things we talked about in the very beginning were, well, we've got to get her foot placement right, we've got to get, her trunk realigned and all of that. So the first couple of activities, I would say like at least 1 to 3 are just trying to get them to activate muscles that are weakened or they're not being used. I'm going to focus more on the trunk and the upper extremity, but I also want to put her foot like in a good position. So is it okay to call you Lauren?
Yeah.
Okay. Lauren, I'm going to reposition your foot here so it helps you out a little bit. All right. So that, see how it's nice and flat? Even though it feels weak, you can get a little bit of a, it can help you out. So the placing and holding and the manual guiding to neutral trunk alignment and then asking for the individual. So we can do a couple things. We could do the side to side, or we could do if she has a posterior pelvic tilt. So since I'm finding her more side to side, the placing and holding of the pelvis, make sure I don't run you over. Lauren, I want you, we're going to shift your hips over just a little bit towards me. Okay. Good, good. Now can you hold it there? Okay, and then relax. Just slump back. Okay, and then I'm going to pull it back over here with me. Good, can you hold it there? Hold it and relax. And so the idea is you keep doing this placing and holding to get her in the position you want. If you feel like she's able to get into it, and if you're able to palpate she's got some muscle activation, she's just habitually not using it, you can say push into my hand there. Come on, kind of push, 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 push. I'm assuming she has intact sensation. I would have already done the IE and all that. So I can either manually place, I can get her to hold, I can have her shift in and out of that position, I can have her shift beyond it a little bit. But right there, just trying to work on that midline placement. The other thing too, if she's reluctant, I would be sitting in front of her, but I'm going to go behind to kind of demo for you guys so you can see a little bit better. If she's shifting over, but even though she's shifting, I feel like she's not really weight bearing on that side, I can pull in approximation, so I can go at her, iliac crest, and I can say, all right, I really want you to put a little more weight. Yeah, right, see, there you go. And so she's sitting up taller. Remember, we've got that postural stability from using our approximation technique. If she was pretty stable here, I could try and say, sit up, sit up. So you can use your hand placement just to try and correct. You're basically looking at, it's not what it should be, and how do I realign it and get her to be in that position a little bit better. Let's see if there's other things for me to demo from back here. One of the things you notice, at first her hand was still to the side. Even though she shifted over, she brought it a little closer. If I felt like she was really relying too much on her uppers, having her bring her hands in her lap, sometimes just distracting somebody. Lauren, can you use this hand to reach up and grab this one? Can you interlace your fingers? There we go. And I want you just to kind of hold that in your lap. So what I've done is by giving her a task she has to focus on, she can't rely on that upper extremity. So that's going to bring her out of that habitual pattern. Okay, so it's really analyzing the alignment and the movement and trying to bring her out of that. Okay. We'll go through a couple with sort of that asymmetrical shift to the side, and then we can go through some of the posterior pelvic tilt as a follow-up example. Now that I've got her almost to midline, I'm sort of moving into 2 with 1 and 2 together, trying to get her more symmetrical, but even, all right, you're doing a great job holding this hand. Can I borrow this for a minute? And then if I bring her out into a position here, encouraging her to weight bear on her hemiparetic side is going to shift her even further onto really weight bearing more on that hemiparetic side IT. Okay, so really getting the pelvis over where we want it to be. I probably shouldn't lean on you to help me get off the mat. Magical moment, don't look at that. Did I ever tell this story when I was working at Lord's? I was sitting down on the floor putting on somebody's AFO, patient with a CBA, and I'm sitting on the floor and I get ready to get up and the patient reaches out and I took their hand and wanted to help me up. My colleagues busted my chops for the rest of the day. I was like, they offered a hand, I had to get up on the floor. Whoopsies. Okay. that floor so far away when I wasn't looking. All right. Let's have you shift for just a minute instead of the asymmetrical and do more of the posterior pelvic tilt and all of that. Okay. So same thing. Good morning, Lauren. Look up here. What color eyes do I have?
I don't know.
Okay, you went from sweet and break my heart to grumpy. Do we need coffee? I know how that works. So you can do the same thing of trying to reposition and move in increments. So she's, you're kind of sitting slumped here. I'd really like to see how up tall you can sit, right? So come on towards me, come up, come up, come up, come up. Good. And hold there. And then relax. Because she kind of slumps back. I think you went further that time. All right, and so then,
More coffee.
Yeah, more coffee, clearly more coffee. And now I want you to hold. Now that you're here, try and hold there. And so here's where I'm gonna judge, is she just having problems getting there and that's where we need to focus? Or once we get her there, can I then give some resistance? Can I, tap her a little bit out of that? If I feel like she's holding up here pretty well, I'm gonna say, I'm gonna push against you a little bit. You try and hold that. Hold, hold, hold. So I'm very focused on her pelvis. What am I ignoring? A little louder. You've had some coffee.
Everything else.
I'm ignoring her head, her shoulders, everything, right? Okay. So it's great that I can get her sitting on her pelvis, but then you're also going to work up to upright. Open your eyes, look straight at me, look over my head, whatever. Look at all the gray hair. Okay, when there was only a few, it used to be, can you see them? Now you can see them all. Okay. So thank you. So that's just trying to get her to, manually guide her into neutral trunk alignment, ask for them to hold. Same thing if she's leaning heavily, having her bring her hands in her lap or not use her hands, really trying to get some of the trunk control. We already talked about making sure that the lower extremity is balanced. And I think I already went ahead and did some of the weight shift side to side of the pelvis beyond neutral alignment. So those things, I would say you can also pull in the visual cues, have them use the mirror, have them self-correct. Do you guys remember, and this is of me genuinely asking, do you remember the scapular patterns from PNF? Or we remember that we did them, but we don't remember what they are? The second one. Okay, got it. Yeah, that's me actually asking. So here's an opportunity to kind of bring them in. Let's see. I forgot. Is your weak side? It's like, look, I made her so upright. I can't tell which is her weak side. So one of the things you can do, so the scapular patterns were anterior elevation, posterior depression. That's one angle, or posterior elevation, anterior depression. So it's like an X. Okay, and patients tend to have, like the involved side scapula tends to be a little lower, and sometimes the scapula is a little bit retracted. And so what I would probably want to emphasize is sort of that anterior elevation to get her out of that. And so I would start with rhythmic initiation. Lauren, I'm going to just move your shoulder a little bit here, and then move it up and forward, and just relax. And then this is sort of the position I want you to be able to get in. So we're going to move it up and forward. And so passively, I'm moving her a couple times. And then I'm going to say, like, okay, now I want you to help me pull up a little bit. Pull, pull, pull. Good. Can you keep it there? Now relax. Let me bring it back. So remember, rhythmic initiation is unidirectional. So I'm only focusing on that, bring it up and forward. And hold. And so then that progression would be carry her passively through it, active assisted, and then a little bit of resistance. So you can pull in with that. If you wanted her to be able to do both movement transitions, so rhythmic initiation is unidirectional. If I wanted her to do the slow reversals, it would be, okay, I'm going to have you pull up and forward, and then push back down and into my hand. Now pull up and forward, good. Push back and into my hand, down and back, good. Up and forward, and down and back. So my hand is sort of, front of the humerus, acromion-ish, and then when she's coming down and back, I'm trying to get like the scapula almost sitting down into my hand so that I can, give her resistance throughout the movement both ways. Up and forward, good, and push down and back. And whichever direction she's doing, I've taken the other hand off. So when she's coming down and back, I only have that hand. When she's coming up and forward, I've got her with those. Because remember your manual contacts and your verbal cues. So that's rhythmic initiation, slow reversals. And then the last one is rhythmic stabilization. And remember, this is more the, kind of posture and balance kind of thing. And so I showed you approximation earlier. Another thing I might want to do once I get her in this position, and I want her to be able to hold it, is ask her to, so let's say I've moved her into this position. All right, you see you're nice and upright. I want you to hold right there, okay? Now I want you to hold there. I'm going to push it a little bit against you. Hold, match me. Hold, hold, hold. Good, match me. And then hold, 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 match me. Good. And hold, hold. And what do you see her doing? Are her eyes still open? What? See the gentleman with the blue hat? What do you see on his shirt?
Letters.
Okay, good. Nice, you covered it up. I know, rude.
It says physical.
Okay, good. So the idea is, it's not so much the movement as getting her to activate those muscles. All right, so she was in a poor posture and alignment. These are a whole series of activities you can do to try and get her to activate those muscles and get into a more neutral, upright alignment. And I would pull in using the mirrors with that. So I think that's a good chunk of things to do. Grab partners, grab mats, put your pillowcases on your pillows, and practice some of these, and we'll kind of circulate around and ask questions. Go ahead, Hector.
Yeah, are you not too focused on the trunk movement then when you're doing that?
That's a really good question. Hold for me for a minute. Hold, match me. As I increase the amount of resistance that she has to match, she's activating more than just the scapula. She's starting to pull in like the trunk muscles as well.
No, I was talking about when you were doing the protraction and elevation.
Yeah, when I was just doing the scapular movement pattern, I was solely focused on the scapula.
Okay.
But then when I went to resisting, that's going to pull in some overflow and have more of the trunk activation as I increase the amount of resistance.
Right. Yeah. Just because I saw she had some rotation. So do you not? You just.
If you feel like that's the component that's missing and you really want to work on that, you absolutely could. It's not what I demonstrated, but you absolutely could work on that. Because if you're doing slow reversals with enough resistance, she's going to have to pull in the rest of the body as well. Okay. Pull up and forward, good, and down and back. Sorry, we're gonna go up and forward, and then down and back into my hand. Up and forward into my hand. Pull. Down and back. Down and back. Up and forward.
Stronger
Pull,
than
pull,
you
pull,
look.
pull, pull. Down and back. Good, and relax. Okay. So this is where it's a basic technique, and it depends. What is she missing? What do you want her to do? We could start with passive unidirectional rhythmic initiation. We could move into both directions. We could move from assisted to resisted, depending on where we think her deficits are. All right? This is not somebody who's dependent to be able to sit upright, okay? So their alignment isn't good, but this is a starting, the things that we were just doing, we were trying to enhance their alignment and their trunk control, but it wasn't someone who was completely dependent. A lot of questions about hand placement as you were doing the different techniques. Any other big questions as we were circling around? I think
Everyone pretty much got it.
yeah, I think everybody got it. It was looking at the subtleties and going through some of that. So several of you, like the mirror was available. You can, once you're getting them into a more neutral alignment, you can use that visual cue. What do you see? Oh, I look slumped, or I look, I'm off to the side. So you can add that. What we didn't demo, but you can practice in the next section, is once you've got them in that neutral alignment, then we showed like shifting further to the side or shifting forward and back. Another way that you can pull the trunk in a little bit more is having them like turn and look over one shoulder, turn and look over the other. And so it's just, you're kind of progressing and pulling in more of the trunk, if that makes sense. I don't know if folks went ahead and did that or not. Just not really anything to demo. straight from that. It's just a list. Oh, another question was, is this a sequential order? We should start with one thing and work our way through. The answer is no. This is sort of a things to go in your bag of tricks. And you reach in and pull out the appropriate activity based on what you see with your patient in front of you. Does that make sense? I know sometimes in previous classes it's been very, first you must do this and second you must do that.
Neuro's never like that.
Team Neuro.
That's the beauty of Neuro.
Right. Okay, so we're gonna move on to item number 7 on the lab. And these are a couple of, doing the transition from sit to stand. Some of it is familiar from what we did in the first 2 weeks, and then some of it is adding a few things to it. So the first item, 7A, is the therapist sitting next to the patient with hand placement to guide the quads and promote, sorry, I'm determined to run over you with the rolling stool at some point today.
Okay, going on disability for a while.
So we're gonna make this be your hemiparetic side.
Sure.
Thank you, he's very adaptable that way. There we, good, you got it.
You can ask RJ.
Okay.
I'm a great actor.
Okay. Oh, I may have chosen poorly then. All right. So clearly, if I'm going to be doing any sort of a sit to stand, I want him in that alignment. I'm going to reposition his foot sort of in like that. Bring it forward just a tad. I'm going to bring you back over a little bit more to neutral. In the beginning module, we talked about if a patient is tending not to rely on their hemiparetic lower extremity and sit to stand, you could use the manual contact to try and guide them. So first you sit to stand the way you'd want to do it, leaning on that side a little bit more. Okay, so you can see he's over to that side, back down. And clearly this is not somebody who's max assist, because I'm just sitting here like sort of holding onto a waistband, but not really, right? So that manual contact that we did before was, okay, I want you to go from sit to stand again. Good. And then back down. All right, and let's do sit to stand one more time. Good. And then back down. So my manual contacts are, in the beginning of sit to stand, you've got some forward translation of the femur over the tibia. So in the beginning, I'm kind of pulling forward, and then when it reaches the point of the motion where he's supposed to be loading and weight bearing more, then the pressure is more down through the tibia. You guys remember that from before? Okay, so we pull it back in here. We did it in chairs before, but when you're sitting with somebody by the mat, you can not only use your hand placement, but you can kind of use your body to sort of guide the motion to it as they're going along. What's new is this idea of B. If needed, the therapist can use their lower extremity to place across the tibia to try and prevent knee buckling. So if you're worried that when they come up, their knee's gonna like buckle a little bit, you can, all right, we're gonna do the same thing. Once you go from sit to stand, come on up, good. And then back down, come on up, good. Now, all I'm doing is putting a little bit of pressure at the back of my calf across his tibia. I'm not yanking it back to cause recurvatum, okay? So I'm there to prevent him from buckling. Let's do this again. Try and buckle on the way up, okay? Sit to stand, good, good. All right, yep, he is a good actor. All right, and then come back down. Bonus points on the attempted buckle.
Nice.
You get extra points. Right, and so I'm very focused with what we're doing here. Your other hand, again, it's going to kind of depend on your patient's alignment. If he's willing to come forward, you may be just guarding. If he's still reluctant to come forward, I may have my hand a little more superior, trying to encourage that trunk flexion. The other way you can do that is I can grab a hold of a gait belt or his waistband, and then I've got my whole arm sort of diagonal across the back of his trunk. And so I can give pressure, I can guide him. I didn't have to tell him anything, right? So I want you to, we're gonna stand up. I want you to put weight on this side. Come on up. Okay, he's very dramatic with the acting too. And sit back down. Good. So you can, I'm guarding with my hand. I'm almost like my arm and my shoulder are almost getting the motion here. Is that what it felt like? Yeah. So The words we say to him are, I want you to stand on this side, I want you to stand up, like the focus on the basics, but you're using your body and your hand placement to try and get all those other alignment things. Once again, not somebody who's total assist or max assist for a transfer. This is somebody who's probably, min assist, contact guard, because I'm pretty confident. And if I know sometimes they buckle, well, I know you did like transfers and things the other day where you could be there and you could block the knee, other ways. But if you want to really work on the sit to stand transitions in small increments, you're in a good position to be able to control that. When you work with your partners, you'll have to figure out your like relative body dynamics or what's the word? Anyway, there are things that work for me because I'm short. So I'm guessing Paul might not do things exactly the way that I do things, right? Yeah, so, okay, I'm gonna go out on a limb and say some things might be different. So for me, it worked really well to use, the back of my leg across the tibia. You might have to adjust your foot placement a little bit more. Let's see. Oh, sort of a variation on that. If I'm really wanting to focus on, this is not, I want that one. Thank you. Now I'm getting like picky. Give me my favorite stool. Thank you.
That was dangerous.
Let's do one.
That was a scene.
What I'm gonna have you do. Nobody called me on it, but his sitting position to go from sit to stand, we probably should have had him scoot forward a little bit first, right? Because he's really kind of flush back. Okay, good. That makes this next thing easier. If during the sit to stand transition, I'm worried about he might buckle forward or he might go back into recurvatum. So I want to do the sit to stand transition, but I also want to work on that knee control as he comes up. You can put your knees like sort of front and back of his knee and his leg. So we're going to do the same thing. Come on and do sit to stand. Stand up. Good. And now try and buckle. Try and snap back into recurvatum. Okay, so I'm here. I can give him, no, I want you here in neutral alignment. Right, so I'm still guarding him back here. I can have some control here in the hand placement, but I can also use my knees to try and say, nope, I don't want you buckling, I don't want you snapping back, I want you in neutral alignment. And now I want you to lean forward with your trunk and sit back down. And good. So he did it perfectly. Sometimes you'll see, that's where you'll see people really start to buckle or really start to snap back because they're afraid of that transition and then they lose control. So you're in a great place. You're using both hands, you're using your knees to be able to get the movement and the alignment that you want. Just getting to balance sitting to actually either weight bearing on the extremity or reaching, all trying to engage the trunk and the upper extremities a little bit more. So we'll go through and demo a couple of them. With, let's see, with item number 8, let's see, which is your side? This is why I like this stool, because I can move. The other one, my hair will fall off. So I'm like,
Just like my coffee is behind us. Over there.
is it under? You're a good PC. So we don't sit. All right. So remember that the patient tends to want to favor their intact side or less affected side. They don't want to really weight bear or use this side very much. So we can do a couple of things to really, not just get them in neutral, but get them to reach across, weight shift more, and use that side more. Hi. Are you my cranky patient, or are you my sweet patient that I started with? Things not to ever say to your patient. I noticed that your arms kind of, does it feel like it's stuck up here? Because I want to put it down to the side. Does it,
Little.
yeah. Okay. So if she was in that habitual posturing, and let's say for right now, we're going to give you some spasticity that makes you tend to posture a little bit more. You remember one of the things we talked about earlier, a technique we talked about earlier with PNF was this idea of rhythmic rotation. So if she tends to posture up like this, you can do sort of a rotation around the long bone, and that gentle rocking and rotation does have sort of an inhibitory effect or a relaxing effect. So I can take her from this, up here down into a position where I can have her weight bear. Okay? If once I place her in that position, she can maintain it, great. If not, if I need to keep hand manual contact on the triceps to try and get them to activate into elbow extension, or just to use support, we can do all of that. Because I placed her hand, let me back it up into, okay. Because I placed her hand, you know, here should be more midline. If I placed her even more out to the side, I'm getting more weight across. I can double down on that and say, yeah, I want you to reach in and grab for the ball. So what are you seeing her do?
Trunk rotation.
Yeah, a lot of weight bearing, a lot of trunk rotation, pulling it on. Okay, and relax. Come up here, come down here. Okay, so this is all based on what you know about your patient, their balance control, and their safety. I don't ever start with, I know in the book there's a lot of pictures of reaching down, getting an object from the floor, getting an object off of a low stool. I think they're great activities. I don't start with those. I don't use them for every patient. But when somebody is doing really well, like they can control their trunk, you know, in sitting and small excursions, then I may want to have them either reach farther and move farther that way.
Especially if you're like trying to send them home,
Yeah.
trying to work on that home
'Cause-
safety stuff, because they're gonna have to do that at home.
They're going to drop the remote, go to get the remote, and you want to know that they can get the remote and pick it up and not face plant and be back in the ER. Okay?
What were you doing with the hand on the elbow? Were you blocking it from buckling?
No, that's a good question. If she's able to keep it there, I'm not going to really do anything. If it tends to buckle because of weakness, I can either physically, now she's going to be difficult. I can physically block it so that it stays there. Or if she's got a little bit of activation, but it's not real steady, I can be there as a manual contact. I can periodically like tap, a little bit of quick tap, just to say, hey, triceps, I want you to hold this position. We did some of that holding and placing before with the trunk. You can do the holding and placing with the upper extremity as well. So I think there's additional examples in figures 2.6 to 2.10 you can go through in the book. And I really I just went ahead and did 9, didn't I? Yep. Okay. A couple of options. Let's say the rhythmic rotation didn't really work. Or I have someone who's got so much weakness that when I put them in that position, they're not going to be able to maintain it. So you can split the difference. And let's say she couldn't go all the way out and maintain it there, but instead I decide I'm going to put her, okay, so she's supported. And this actually might be a good one if I have somebody who has subluxation and I want to get them in a good position. I could, get them, weight bearing through have you in closer through subluxed. But there we go. So the idea is I can work in full weight bearing, fully extended, or if I don't think she can do that, I could have her weight bearing on a stool with a pillow, take one of the wedges, all of those options. Okay, so looking at what they have and how do you take them able to do a little bit more. You write down instructions so that I am focused. Ha 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 ha. Let's say she can do this pretty easily. How could I progress this weight bearing on an elbow to make it a little more challenging and make it heading towards a functional skill?
Farther out.
So farther out makes it harder. What else would make it harder?
Compliant surface.
Say it again.
Like leaning on a compliant surface, having to do.
Yep, a flexible surface. What else? And what would I do before I had her push up?
What do you mean?
Well, I'm gonna ask you what you mean. Push right back at you.
Because that can help with pushing up out of bed,
And so that's where we would, if I'm trying to play ahead to how this could become even more functional, maybe this is an interim place that we're working with. And then she gets pretty good here. I want to make it a little lower. I wouldn't do it that way. But eventually, let me pull this out all together. I don't want to knock over your coffee. I know better than that. Ultimately, I'd like to be able to get her down to be able to do this and then push back up so that she can do that transition to sideline. Okay? So if you have somebody that you know what their bed mobility is and they're having trouble with that transition, this would be a great activity to work on for that.
I like that going both sides too.
Yes.
you could activate the trunk on the intact side, trying to facilitate getting this, and then this side, the hemiparetic side, using the arms, so whatever your goals are and what you're trying to strengthen.
Yeah. It's a great, and again, it's a little thing with the trunk, but it's so functional, and it helps them get more confidence and relearn how to control the core muscles. So I think that's kind of 8, 9, and if you go through 11 with the pictures in the book, that's where they're reaching forward to the item on the floor or on the stool. With 12, there's, in your text, there's a list on page 190 of a variety of bimanual activities. And then figure 519 shows a lot of different activities. So remember we had the patient in the very beginning who tends to favor their intact side, not use their hemiparetic side very much, even if they have the capability. So I saw some people, you were, putting a target out here and making them use their trunk and not be able to have that asymmetrical posture. You can also, Lucas, can you grab the basket and bring that over? Yeah, thanks. And so this, this would have to be somebody who has at least a little bit of growth grasp in their hemiparetic side. But if I've got you holding onto a basket or the cafeteria tray or something like that, I've taken away her ability to rely so heavily on her intact side, and I'm making her use more her trunk because she's engaged in a bimanual activity. There's no magic to what bimanual activity it is. So it's carrying a basket, it's carrying a tray. I think one of the other pictures in the text is using like a playground ball and rolling side to side. The idea is you've got them activating, maintaining a good position and good control of their trunk, and then doing some bimanual activities. Does that make sense?
A lot of tapping and cueing, right? And then using like hand positioning. So, where's your, okay. I'm always like a kneeler, or you can use your, as long as you're in your scrubs, then you can walk with them. And it depends, because I'm short too, so sometimes I feel like I can get in that better position and be like closer to people. So again, you're gonna look at their posture, maybe fix their foot. All right, we're gonna put your foot in a good position here, okay? And I want you to scoot forward in the bed for me, okay? So use this hand to push, use your legs to push, and we'll come forward. You can grab, if you have Chuck, if you're in the acute care setting, if you're in a more chronic phase and you're not, they don't need that a lot of support, you can do like the leg techniques and try to scoot and use their pelvis and bony prominences to try to kind of get some forward translation. You can use one butt cheek at a time, like stuff like this. Trying to incorporate the hemiparetic limb to kind of help you this way, right? And then side to side, similar. All right, so let's scoot this way. Use this leg to help you and use your arms. I want you to push through this side and push through your leg. Where am I going backwards? Sideways. Right? And then towards, you can use hand placement this way. Like stuff like that. If you're in a clinic and someone's wearing pants or a gait belt, you can try to help using that stuff too. I think I would also try to think of trunk positioning skills that you can use to incorporate like your scooting, like trying to use like momentum, using this kind of thing to help you scoot sideways. Think of compensatory techniques, like using your head and shoulders and momentum, like stuff like that. Am I saying? Yeah, you want to practice that? All right. Protecting yourself and your back, so wheelie chair. So you don't have to squat your way through this. You can do it squatting and kneeling, but you will fatigue before the patient. All right, which side do you want to be on Friday? All right, so we're gonna assume that this patient has good trunk control, and we're gonna be guarding the leg, and you can use your good arm on here to pull up, and let's do, like either over the lip or, you don't have to do steps. All right, all the stuff you learned this morning, facilitating your sit to stand, right? All right, you ready?
Mm-hmm.
You can,
RJ.
she can use this arm,
Should push or would she pull?
Oh no, I got it.
depends on what your goals are, right? If your goal is just to get up and walking, this is an easier position for the patient. The patient can pull and use momentum. If they're pushing, it's going to be harder for them because they're gonna be like that video that we saw, the guy that goes backwards. So I would let her do whatever's easiest at first.
Okay.
You can facilitate from the hip too if you need it, the pelvis. You can do, depends on how unstable this leg is, but let's assume there's like almost nothing in here. All right. And 1, 2, 3. We get momentum and up. Good? All right. Now I would have my aide or someone following with the chair, and depending on how much assistance, there might be another person on one side to control the trunk and guard on the trunk. Because my job as PT down here is to solely focus on this leg, and I don't want to be worried about what's going on up here. All right. So someone to keep her focused and say, look up, we're going to posture, guard, whatever. So if someone wants to jump in and do that, you can. Anyone?
Do you want me to guard her too, or just kind of like?
No, guard her too. You can even like have a hand on her belt. Yeah, she would have a gait belt too. Or pants, depending on your setting. Okay, so all of the things that you did in the sit to stand come together. Use your tapping, your facilitation, your guarding, and everything. So we're gonna do. You okay?
Yeah, no.
Oh, okay. Advancing the limb, assisting with dorsiflexion, guarding the knee, preventing recurvatum, all of that stuff at once. And depends wherever you want to put your hands. Usually I will definitely have one right above the knee so you can facilitate blocking, and then use the back of your fingers to prevent recurvatum, and down at the ankle. And then a lot of communication with your helpers and your patient for left, right. Because a lot of times patients with a stroke, especially if they can't feel this side, they'll start stepping before you're ready. So a lot of communication. Not yet. Lock this knee. Okay, now left. Like that kind of stuff. Ready? All right, so we're going to start with your right leg, okay? All right, take a step. Right, left. Good. Right. Good faking. Okay, left. Good job. Right. Left. Right. Left. Good job. All right. If you needed to get closer to the patient or you didn't have the parallel bars, go out one side. Like let's say you were in a hospital setting, you'd have another person at the bottom, and then your aide or your PT aide or PTA could be over on this side, helping with weight shifting and pelvic stabilization too. So practice, same thing. We can practice that. The other thing I use every once in a while when I am by myself and have a very secure patient is we have railings in the hallways of our hospital, so she can use her good arm and assume this arm is flaccid. I can be over here and guard. And then use my leg, right leg, left, right, left, right. Good job. All right, so you can practice all that. That is with a patient that has like a pretty good trunk that I trust, because I feel like that would fatigue me very fast, and also you don't have a chair directly behind you, so you would either have to do a step, grab the chair, lock it, whatever, or be confident enough to like have the patient here and grab a nurse or someone to bring the chair up when you're done. Good? All right, you guys want to practice?
Yeah.